Good afternoon, colleagues, and thank you for joining us for this webinar. I am Dr. Shanti St. Anthony. I am the Knowledge Coordinator for the Pan-Caribbean Partnership Against HIV and AIDS, PANCAP, based at the PANCAP Coordinating Unit in Georgetown. Let me extend a warm welcome to you on behalf of PANCAP Director, Mr. Derek Springer, and thank you in advance for joining us. Today, this afternoon, we will be sharing updates from the recently concluded 10th International AIDS Society Conference on HIV Science in Mexico. Before we proceed, I'd like to share with you a few housekeeping notes. Firstly, your mics are muted. So if you have questions, I ask that you type these in as the webinar progresses. We will take your questions after the presentation. Secondly, we're recording the webinar and we'll share the recording on PANCAP's website for the benefit of the PANCAP partnership. Finally, you will receive in your emails a post-webinar evaluation. I encourage you to complete and share your thoughts and impressions. This will be useful for us to enhance future webinar experiences. As mentioned earlier, today's webinar is on updates from the International AIDS Conference on HIV Science in Mexico City. Our presenter this afternoon is Dr. Giovanni Ravasi. Dr. Ravasi is no stranger to the region. He's a medical doctor specialized in infectious diseases and public health, with experience in HIV and STI clinical management, training and mentoring, surveillance and research, and technical cooperation on HIV prevention, care, and treatment, policy development, implementation, monitoring, and evaluation. Quite a lot. Since 2008, Dr. Giovanni has worked for the Pan American Health Organization, PAHO, as the Regional Advisor for HIV Drug Resistance Prevention and Surveillance. And since 2014, for HIV and sexually transmitted infection care and treatment, based at PAHO's headquarters in Washington, D.C. Dr. Ravasi attended the International AIDS Society Scientific Conference on HIV Science in Mexico City, and he will present to us this afternoon on WHO policy guidance on event-driven PrEP and prevention and control of sexually transmitted infections in the era of pre-exposure prophylaxis. I now hand you over to Dr. Ravasi.
Thank you so much, Dr. Singh, for this introduction, and it's a great honor to collaborate with PANCAP, and a great opportunity to present these two new, sorry, there's an echo. These two new technical briefs from the World Health Organization that were recently presented at the International AIDS Society Conference in Mexico City. One on event-driven PrEP, a new dosing schedule for pre-exposure prophylaxis for men who have sex with men, and some considerations regarding the prevention and control of sexually transmitted infections in the era of PrEP. So I will start by giving some background information on the progress towards ending AIDS in the region and some of the gaps, the WHO recommendations on HIV combination prevention and PrEP, and then present the details of these two new technical briefs, event-driven PrEP and PrEP and STIs. So this is from UNAIDS, from the latest report that was released also in the month of July. And why is important to keep focusing on prevention, and why is PrEP a priority? Because basically, we are seeing a slow reduction in the in HIV incidence, and definitely insufficient to meet the 2020 target of advancing towards the epidemic control. And in 2018, still 1.7 million new infections occurred worldwide. So the situation is very different across regions, and the Caribbean is actually well positioned with a 16% reduction in the number of new HIV infections per year between 2010 and 2018. Although, as you can see from the graph, the reduction in the last few years has been limited. So we really need to give a strong push to prevention, innovating prevention interventions, and providing them with an HIV combination prevention approach. And PrEP is I would say now relatively new technology, but still new as far as progress in implementation in many regions. So the other update on the epidemiological situation is that in the Caribbean, the composition of the new HIV infection is quite varied. 53% is in what we call the general population, and around 47% in key populations and their sexual partners. So it is important to provide a variety of prevention options that each individual, from a person-focused perspective, will be able to adopt based on their specific needs and preferences. And it's not just about providing traditional and innovative biomedical interventions, but of course it's important to maintain the behavioral one, the risk management and reduction interventions, as well as addressing the structural barriers of stigma, discrimination, violence, legal barriers that may represent an obstacle for persons to access healthcare, and especially members of key populations. So two messages: there's no one size fits all. HIV prevention should be provided as a range of options. And the second key message is it should be provided as a combination approach: biomedical, behavioral, and structural. And PrEP, as you can see, together with post-exposure prophylaxis, is one of the biomedical component of combination prevention. WHO since 2014 published also a specific guidance on the provision of HIV prevention, diagnosis, and treatment for key populations. And again, it's from a combination prevention approach with health interventions, structural interventions, and PrEP is definitely, since 2014, part of this package. This slide provides you with an overview of the evolution of WHO recommendations and technical guidance on PrEP. In 2012, the recommendation was to start implementing demonstration projects, moving to a strong recommendation for PrEP in men who have sex with men in 2014, and 2015, because of the strong evidence of good quality, PrEP was recommended for people at substantial HIV risk, regardless of their belonging to a specific population group. And in 2015, the recommendation for PrEP was a strong recommendation with a high quality of evidence, and PrEP was recommended as an additional option for persons at substantial risk, and of course also always as a package of services with a combination approach. Since 2017, WHO has released a series of orientation and implementation tools, as well as different media for dissemination and capacity building on PrEP. And these two new technical briefs that I will be presenting today are part of these implementation aids that were recently released in 2019. So, but a couple of considerations on PrEP. PrEP works and is highly effective in preventing HIV infections, and this is the evidence from a variety of clinical trials, including some randomized clinical trials that provide the highest quality of evidence. And the reduction in HIV infection can be as high as almost, let's say, 95% if PrEP is taken correctly. And this is in the context of clinical trials. But of course, PrEP is good for preventing HIV, but not for STIs and hepatitis. Some HIV infections occur very rarely, even in persons on PrEP, because of HIV drug resistance viruses or because of low adherence or PrEP interruptions. And PrEP requires periodic HIV STI testing and lab monitoring, and because of the above, a combination prevention approach. But PrEP also works beyond clinical trials, and there's an increasing body of evidence from large metropolitan areas where PrEP has been implemented in the last few years, where a reduction in the number of new HIV infections diagnosed in men who have sex with men has been observed. And the experience of New South Wales and Sydney in Australia is one of these, with as much as a 25% relative risk reduction in 12 months after the rollout of access to PrEP in the metropolitan area of Sydney. And of course, this is the result of a partnership between civil society, academia, and government in the provision not just of PrEP, but PrEP as part of a combination prevention approach and access to testing and treatment for all. So where are we globally with PrEP? Right now, 73 countries have developed PrEP policies with additional 23 pending. And the Caribbean is, I would say, pioneering the region with 5 countries: Bahamas, Barbados, Cuba, Dominican Republic, and Haiti, with PrEP policies being implemented. On the other hand, the number of people, regardless of this advance in policy development, the number of people on PrEP is still quite low. It's around 300,000 worldwide, and in the Americas is around 170,000, but the majority are in the United States, and actually only around 500 or less are currently on PrEP in the Caribbean, and it's an information updated at July of 2019. So now it's the time from policy development to policy implementation, demand generation, and really accelerated scale up. So in this phase of implementation, and especially considering that in many countries, the population of men who have sex with men has been the one that has led the community-based advocacy for access to PrEP, and also accessed PrEP, especially in countries with more concentrated epidemic. This new technical brief represents a good opportunity to diversify PrEP dosing options and promoting access. So again, what is included in this technical brief on event-driven PrEP? First of all, the current scientific evidence, the base of evidence that was used to develop this guidance about safety and efficacy. A discussion on the rationale of offering event-driven PrEP as an alternative to daily oral PrEP for men who have sex with men, of course, always as part of comprehensive HIV prevention and sexual health services. Right now, the recommendation or the guidance on event-driven PrEP is for MSM only, because there is no evidence of use of event-driven PrEP, or let's say of effective and safe use of event-driven PrEP in women, transgender persons, and heterosexual men. This brief also includes details on the dosing considerations and for oral PrEP containing tenofovir, and messaging on how MSM can switch from event-driven to daily dosing and vice versa. So what is event-driven? In the literature, you may find different definitions: intermittent PrEP, or event-driven PrEP, or WHO developed a short, more catchy name of PrEP 211. What does that mean? The 211 dosing comes from the IPERGAY study, which is the first clinical trial that proved the effectiveness of this event-driven PrEP, and it consists of 2 tablets taken between 2 and 24 hours before sex, 1 tablet 24 hours later, and 1 tablet 48 hours after the first intake. So that's why it is defined as PrEP dosing 211. So it's a total of 4 pills of tenofovir emtricitabine taken over 3 days to cover 1 sexual intercourse. So more on the IPERGAY results. What was observed in the 2 arms of the intermittent or event-driven tenofovir emtricitabine PrEP versus placebo was an 86% relative reduction in the incidence of HIV. So 14 cases in the placebo arm, 2 cases in the tenofovir FTC arm, and which corresponds to an incidence of 6.6 compared to 0.9. The open label continuation of the IPERGAY study was also analyzed later in 2017, and no further cases of HIV were observed in the on-demand arm, which brought down the comparison of between the event-driven PrEP arm and placebo to 6.6 to 0.19, and a 97% relative reduction of the PrEP, intermittent PrEP or PrEP 211 versus placebo. And even analyzing PrEP on demand or event-driven PrEP. As you can see, we're switching from one definition to the other one, but what WHO is now using is event-driven PrEP or PrEP 211. So the same observation of high effectiveness of PrEP on event-driven PrEP was confirmed, even analyzing a subpopulation of men who have sex with men with less frequent sexual acts. A second study that provided evidence for this recommendation is the Prevenir Study, an open-label prospective cohort study in the Paris region. which included up to 3,000 participants, HIV negative with a history of inconsistent condom use, no renal function deficiencies, and no hepatitis B antigen carriers. And participants could opt for either daily or on-demand PrEP and could switch from one regimen to the other one during the study. And one first important information is that, well, the vast majority of participants were men who have sex with men, and the distribution between the two regimens, daily and event-driven, was about 50-50. Which is important to know because it really provides evidence that there is demand and preference for a regimen that it's not every day and that can be adapted to the frequency of sexual acts of each individual. And the proportion of people distributed between daily and on-demand, as you can see, did not greatly vary during the study. So another important aspect was that the use of daily and on-demand PrEP was maintained and followed during the time of the study with correct use above 95% in all groups. And in about 20% of participants, PrEP was used with condoms. So in the Prevenir study, and this is the latest result from IAS, only 2 cases were observed in the study, both in the event-driven or on-demand PrEP arm. And the global incidence was 0.09. Compared to the 6.6 of the placebo arm in the IAS study. It's very low. And the 2 cases that were detected were actually cases which the PrEP users had stopped PrEP and were infected after because of ongoing condomless sex during that period. Some additional information that it's from the Prevenir study, an increase in 43% was observed at 3 months in the number of sexual intercourses, but at the same time, a reduction of 20% in the number of sexual partners. And an increase in 21% at 3 months in condomless sex for the last sexual intercourse, and an increase in 15% in receptive condomless sex for last sexual intercourse at 3 months. So at the same time, the incidence of bacterial STIs was increased in the population on PrEP, about 38% per year. And more in the daily PrEP arm compared to the on-demand arm. And finally, the safety of both arms was comparable with less than 1% of cases of reduction in the creatinine clearance below the threshold of that requires PrEP interruptions. So overall, the evidence from these studies is demonstrates the efficacy and the safety of using event-driven PrEP, but of course, it provides some level of evidence in the change in sexual behavior and in a possible increase in sexually transmitted infections. And we will come to that in the second part of the presentation about the technical brief on PrEP and STIs. But to conclude on the event-driven PrEP, there are other, there's plenty of evidence about the acceptability of this dosing schedule, and especially when is offered as an equal option with the daily PrEP, such as in the Prevenir study with a 53% in preference of daily PrEP. When it's offered as an alternative, then the choice of event-driven PrEP is lower. But in the US, there's also evidence that 74% of MSM who declined daily dosing found an event-driven PrEP dosing acceptable. So it's a good option for MSM that may find event-driven dosing schedule more convenient. So for whom is event-driven PrEP appropriate? Well, as I said, for MSM who find more effective and convenient taking medications not every day, only when they are expecting to have sex. Also when MSM have more, let's say, infrequent sex, for example, less than 2 times per week. Otherwise, it's probably easier to take daily dosing. And also who can plan for sex at least 2 hours in advance, or who can delay sex for at least 2 hours, because PrEP needs to be taken between 2 and 24 hours before sex. For whom is event-driven not appropriate? For cisgender women or transgender women, transgender men having vaginal frontal sex, men having vaginal or anal sex with women, because there is no evidence of safety and efficacy in these populations, and people with chronic hepatitis B infection, because the drugs that are used for PrEP are also effective with the hepatitis B virus, and the interruption could cause flares. So the 211 was taken directly from the Ibergate study with 24 hours before sex, 1 pill 24 hours after sex, and 1 pill 48 hours after the first intake. And it's really important at the beginning, when people are enrolled in PrEP, to have an assessment of the HIV risk patterns and the frequency of exposures, to assess not just the eligibility for PrEP, but also to be able to offer and discuss with the client whether a daily dosing is more suitable or an event-driven dosing is more convenient. And of course, risk may change over time, and the frequency of exposure may change over time. So at every follow-up consultation, it's important to check if the current PrEP dosing is still the more convenient, and switching from one to the other one is definitely possible. Regardless of the dosing schedule, the follow-up calendar is the same, and the recommendation is 1 month after initiation, and then every 3 months for regular checkups and HIV and STI testings, counseling, and provision of other prevention interventions. So what are the advantages of event-driven PrEP? It offers flexibility, choice, convenience for men who have sex with men who may be at high HIV risk for brief periods or have sex infrequently. It's adaptable to seasons of risk. User clients can change from one to the other one. It's less pill burden, less toxicities, reduced costs for programs, and it may improve continuation of PrEP among MSM who find daily pill taking challenging. There are some disadvantages. It needs some planning before sex. It needs remembering to take the post-sex dose at 24 and 48 hours. It can be potentially stigmatizing because since event-driven PrEP is only for MSM, a man taking event-driven PrEP may be identified as MSM, and definitely adolescents, for which we know that adherence to PrEP is an issue, they might require additional efforts to ensure adherence to an event-driven dosing. So in conclusion, for this event-driven PrEP part, event-driven PrEP is safe and highly effective in reducing HIV infection in MSM. But event-driven PrEP is not for all, so it's important to provide both options, daily and event-driven, and it is possible to switch from one to the other one. So countries are encouraged to include both daily dosing in their guidelines and protocols, and education and support is important for clients as well as providers to be able to offer adequately one or the other. And HIV testing is recommended still every 3 months regardless of the dosing schedule. For M&E purpose, we want to be able to monitor the use of PrEP, both daily and event-driven, but because event-driven is only for MSM, in settings where same-sex activity is criminalized, it's important to have confidentiality and data protection when collecting information about event-driven PrEP users. And definitely from the research side, we need more data on event-driven PrEP in other populations. And the brief is now available on the website, on the WHO website. So quickly on the PrEP and STIs. STIs, especially curable STIs, are still an important public health issue worldwide. And up to 376 million new cases are estimated of curable STIs per year in adults between 15 and 49 years. And the main aim of this technical brief is really start from learn about the impact of PrEP on STIs to really turn it into an opportunity to strengthen the prevention and control of STIs through the implementation of PrEP and HIV combination prevention strategies. Why do we need to boost the response to STIs? Well, because as I said, the morbidity and complications that are related to STIs is quite high, especially in some populations. Asymptomatic STIs can be a cause of complications such as infertility, STIs have received less attention both nationally, programmatically, but also internationally from the perspective of donors and technical cooperation partners. So there's definitely need to emphasize the importance of addressing STI from a public health perspective. Prevention efforts are declining. There's an observed reduction in condom use, especially in younger generations. There are limitations in syndromic case management that still the majority of countries are adopting. Diagnostics are expensive and not available in all settings, and partification is underutilized for STIs and also for HIV. And surveillance systems for STIs are weak in many countries. These are just some general considerations, not specific to this region, but that it's more from a worldwide perspective. And since 2016, WHO has published a sexually transmitted infection global health sector strategy that really tries to address all these gaps. So let's see what can be the mutual benefits of PrEP and strengthened STI services. First of all, as we said, PrEP is not delivered by itself, but is part of a broader package of services that really configure a sexual health package. It includes HIV testing, it includes partner notification, a smarter promotion and provision of condoms, contraceptive choices, and STI services, screening and treatment. So when planning the implementation of PrEP, all these associated services should be included as part of comprehensive and integrated sexual health services. So PrEP users, by eligibility criteria, are persons at substantial risk of HIV and therefore also at substantial risk for STIs, and is a core group that should be targeted for STI prevention and control. The prevalence of STIs in PrEP users is usually quite high, and that is expected because having had STIs in the last 6 months is really one eligibility criteria for PrEP. PrEP users at substantial risk for HIV and STIs are linked and retained in comprehensive sexual health services. So the fact that populations that are traditionally more difficult to reach are now linked and retaining services should be seen as an added value of PrEP. And improved STI services will also maximize the impact of PrEP on HIV prevention and the reduction of HIV transmission. So what are the opportunities for optimizing STI prevention while introducing PrEP? There's plenty of global strategies and action plans on STIs, HIV, viral hepatitis, antimicrobial resistance, especially from the perspective of gonorrhea, cervical cancer. So countries should really try to update and strengthen the national STI frameworks, creating the links among all these different areas. Update national STI and HIV combination prevention PrEP guidelines and protocols, introducing new recommendations from WHO, especially on the STI treatment side, integrating training of human resources while introducing PrEP, strengthen STI screening and management training, integrate service delivery. As I said, it's not just PrEP, but it's PrEP and STI and hepatitis and HPV vaccination and screening, and HAV, HBV vaccination, HBV and HCV treatments. So these are all in the service delivery integration benefits that can be taken. Engage community. The community has been greatly engaged in HIV, but much less in advocacy for better STIs services. Introduce new technologies, moving from syndromic to etiological approaches through the introduction of rapid syphilis testing, dual HIV syphilis testing, as well as point of care for gonorrhea and chlamydia. And there's definitely need to negotiate better prices for STI commodities and using the currently available pooled procurement and negotiation mechanisms. So a few final messages for a call to action on STIs. PrEP is highly effective in reducing the risk of acquiring HIV, and the benefits of PrEP at the population level are starting to be reported. The service delivery integration of PrEP and STI services as comprehensive sexual health services offer mutual opportunities for improved efficiency and effectiveness through a combination HIV STI prevention approach, especially because we're targeting people at substantial risk, engaging and retaining them in services. But advocacy is needed to ensure that STIs are prioritized, adequately funded by ministries of health, donors, and other stakeholders. And it's time to move beyond the syndromic management of STIs now that better diagnostics are available, although there's still a challenge of cost that can be overcome through consolidated demand of countries and price negotiations. And also aim for greater innovation in the next generation of interventions and service delivery for STI control, for example, self-sampling, self-testing, pooled sampling, antibiotics for PrEP, post-exposure prophylaxis, multi-purpose technologies, PrEP and contraceptions, and so on. All these are new areas of research that are being studied. And just one last information to know more about PrEP. There are now new learning tools. There's an app that can be downloaded on smartphones and tablets. And there's also a new self-learning course on clinical aspects of PrEP that is now available on the PAHO Public Health Campus with 4 modules about identifying PrEP candidates, starting and managing PrEP, special situation arising to manage issues during follow-up, and counseling and effectiveness and safety of PrEP and avoiding stigma. So I really invite you to check out this course. Is an excellent base to know more about PrEP. And thank you very much.
Thank you so very much, Dr. Giovanni Ravasi. And I invite participants to send their questions in. At this time, I'll share 2 of the questions we have so far, Dr. Ravasi. The first question is, how much time is needed for tenofovir to get to the levels that's necessary in the blood so that one can have safe sex? That's the first question. And the second question is, the studies that you've shared show that sexually transmitted infections increase. And so the question is, what is the evidence saying? Why is it increasing? Particularly, as you noted, that it's increasing more in persons who are on daily PrEP versus persons who are on PrEP on demand. So what is the evidence showing? Why is it increasing, and why is it increasing more amongst persons who are on daily PrEP compared to persons on PrEP on demand? So if you can take those now.
Yes, absolutely. So thanks for the questions. The first one, easy. The second one is more challenging. So I can go back to the 2-1-1 dosing schedule. So for MSM, now the loading dose of 2 tablets of tenofovir emtricitabine is sufficient to reach protective levels of PrEP. So for MSM only, a user could start right away with event-driven PrEP with the 2-1-1 and be protected immediately, or could start with the daily dosing, but nevertheless with a loading dose. So 2 tablets of tenofovir emtricitabine the first day, and then 1 tablet per day as usual. So this will immediately provide a protective coverage regardless of daily or event driven, but for MSM only, because for the other populations, then it's the usual dosing of 1 per day, and the time to reaching the protective levels is still 1 week based on current evidence. Regarding so the question on STIs and STIs and yes, so PrEP, the 2 dosing, probably the higher level of STIs in daily dosing in MSM, and it's something that has been observed in other cohorts, is just because of the more frequent, the higher frequency of sexual intercourses, and together with a slight increase in condomless sex in this population. So that is mainly the explanations. And so the message from a public health perspective is that really the prevalence and incidence of bacterial STIs is high in PrEP users, is usually already high when we detect, when we enroll PrEP users on PrEP, and there's an observed increase over time. But rather than being a concern to prevent offering PrEP, it should actually be a call for an opportunity to strengthen STI prevention and control services, because the impact on HIV incidence is so high at a population level that it really should not, the concern on STI should not prevent providing PrEP. But it's certainly a call for making sure that while we prevent PrEP, we also offer adequate screening, treatment, counseling for STIs and viral hepatitis. And while we implement PrEP, we take the opportunity of update protocols, retrain staff, and make sure that services are up to speed to expect some increase in STIs, but also to detect them earlier and treat them earlier and break the chain of infections through adequate partner notification systems. So, and this is something that may, on a more, let's say, mid-long-term level, have a positive impact on controlling STI epidemics, as some modeling studies have shown. So you might have an initial increase, but then since you're detecting and treating earlier, you may be able to, in fact, have an impact on the clusters of STI transmission at the population level, and at the end, a reduction in incidence.
Thank you so very much, Dr. Giovanni. I have 2 more questions here. The first question, is there a risk of developing resistance to ARVs used in PrEP once implemented widely? The second question is PrEP, that is, its respective drugs, available in Jamaica? Is a prescription required?
Okay, so the first question about resistance, the risk of developing resistance when a person is infected while taking PrEP is very, very low. Well, first of all, it's very, very low, the risk of infection while on PrEP. As you could see from the Prevenir study, is 0.09 per 100 person year. So it's really 2 cases out of 3,000. And in those 2 cases, the chance of drug resistance is even it's very low. So at the end, the impact of implementing PrEP on resistance is very negligible. But there's one concern, and it's well known, well described, and that's when a person starts PrEP while having an acute infection, so during the window period. In that case, if an acute infection goes undetected at the beginning, then the risk of developing resistance is around 27%, if I'm correct. And in most cases is resistance to the 3TC, FTC, lamivudine, emtricitabine component, not the tenofovir component of the PrEP regimen. So it's really important to make sure that the screening strategies are able to pick up recent risk exposures, clinical syndromes that may be an acute infection, and also making sure that a first test is performed at 1 month, so that you're able to soon pick up any infection that had been undetected at entry. In some countries, the use of 4th generation tests or even viral load tests in individuals with a clinical suspect of acute infection has been adopted, but it's currently not an, let's say, strict part of the guidance or PrEP screening to use these kind of tests. The other question about Jamaica. So as far as the country has reported in the United Nations data collection system and the information that we have at PAHO, Jamaica is in the process of developing a demonstration project for MSM, for men with STIs, and for serodiscordant couples. So for the time being, and probably in the next few months, PrEP will be available within the context of this project. So for persons from Jamaica, I would encourage to contact the Ministry of Health for more information. It is possible that PrEP may be available also in the private sector, but in that case, it would be provided through private general practitioners.
Thank you very much, Giovanni. And just to add to the question, the response to the question from Jamaica, I think it'd be good for the person who posed the question to also check with Jamaica AIDS Sport for Life. I will be sending the information to you in an email once the webinar is concluded. Having said that, on that note, I will now bring this webinar to an end. I wish to extend a big thank you to our presenter, Dr. Giovanni Ravasi. This has been a great collaboration between the Pan-Caribbean Partnership Against HIV/AIDS PANCAP and the Pan American Health Organization. Dr. Ravasi, it's always a pleasure working with you. Thank you very much. I thought that the presentation was very insightful. It did present much food for thought as we in the region continue to build our PrEP knowledge base so that we can increase access to PrEP for our clients. Thank you, colleagues, for participating in this webinar. I trust that you're all very equipped to advocate and work collectively and collaboratively with stakeholders in your respective countries so that we can advance PrEP. Dr. Giovanni in his presentation did say that the pace at which we're reducing new infections has slowed over the last few years, and that we must have to take on board all prevention modalities that we know are effective and are working. And so PrEP works, the science is strong. And so I encourage you to continue to work so that we can have PrEP implementation in our countries. Just as a gentle reminder, this webinar was recorded and will be shared on the PANCAP website. Also, I encourage you to complete a post-webinar evaluation. We will highly appreciate your feedback. Finally, I encourage you to stay engaged with the partnership and to join us for our next webinar that will be on Tuesday, August the 27th, same time, as we continue to share updates from the 10th International AIDS Society Conference on HIV Science. Dr. Giovanni Ravasi will be presenting again on the use of dolutegravir as the preferred first-line regimen for adults living with HIV. Thank you all very much and have a good afternoon.
Thank you so much, Dr. Singh. And I'm available through the partnership and the PAHO country offices for any additional questions and support. Thank you.
Thank you, Paul.